Hello everyone, this is Dr. Meenakshi Gupta. Today I am going to continue my topic on drugs for the bronchial asthma. So this is the third video on the drugs for the bronchial asthma. So in the first video I mainly focused on the pathophysiology of the bronchial asthma. Then in my second video I have covered this bronchodilator, this part, and today I will be covering the rest of the drug which we use for the treatment of bronchial asthma. So let's get started with the after the bronchodilator, which includes sympathomimetic, anticholinergic and methylxanthine. The second group of the drug which we use for the treatment of bronchial asthma, that is anti-inflammatory, and under this comes mainly corticosteroids. Now how the corticosteroids they are going to act, or what is their mechanism of action? So they are not a bronchodilator, but they are the mainstay of the treatment in most of the asthmatic patients. Now how they are going to act? So already I have told in the pathophysiology that currently it is recognized that bronchial asthma there is a inflammation in the airway associated with bronchial hyperresponsiveness. So what the corticosteroid they are going to do? They are going to inhibit one important enzyme, that is phospholipase A2. It is phospholipase A2. So they are going to inhibit this enzyme. Now what is the action of this phospholipid A2? It is going to convert the membrane phospholipid into arachidonic acid. Okay, and the corticosteroids they are going to inhibit this. Now, what is this arachidonic acid? It is going to do this arachidonic acid. It is further metabolized by two enzymes. One is cyclooxygenase and other one is a lipoxygenase. And with this pathway, cyclooxygenase pathway, there is a formation of various prostaglandins, so which are also important mediator of the bronchial asthma. And the most important is leukotrienes. This is found. So various type of leukotrienes, like important is LT, C4, D4 and E4. And what all these they are going to cause? They are going to act on cystenyl leukotriene receptor. By binding to the receptor, they are going to cause the bronchoconstriction. Now, what the steroid they are going to do? They are going to act on this enzyme and they are going to inhibit both the pathway. So, no mediators they are formed. There is no release of mediator. So, they are going to inhibit the bronchoconstriction. Ye nahi hogi. No bronchoconstriction will be there. So, they are going to take care of that. And the another important, what are the other action of this corticosteroid? So, number one is they are going to inhibit the formation of the various mediator which are responsible for the bronchoconstriction, which are going to increase the mucus secretion, which are going to increase the vascular permeability. So all that will be suppressed with the corticosteroid. So other action is they are going to, so this is a number one. So other important action is they are going to increase the responsiveness of bronchial smooth muscles to the beta-2 agonistic drug. See, when we use beta-2 agonistic drug for the long term, there is a that causes the down regulation of the receptor. So they won't show for the sensitivity. So bronchial smooth muscle, they do not show the sensitivity to the beta-2 agonistic drug. So corticosteroid, it is going to restore that sensitivity. Then number three, they are also going to cause the eosinopenia. So they are the few mediator which are released from the eosinophil. If you remember, what are the important eosinophilic cationic protein, eosinophilic major basic protein, and they cause what? They are going to cause the damage to the bronchial epithelium. So what will happen because of that? Now the stimuli, now this becomes hyper responsiveness because of the damage of the bronchial epithelium. So what the corticosteroid they do, so you can see here from the eosinophil, these two, which is going to cause the epithelial damage. And what will happen? The irritant receptor and C fibers, they are more exposed to the irritant stimuli. This causes the airway inflammation. So the corticosteroids, they inhibit what? They are the anti-inflammatory. This action, they also inhibit bronchoconstriction. They also take care of this airway hyper responsiveness. So corticosteroids, they are going to give a complete response, complete and sustained symptomatic response in the bronchial asthma patient. That's why they are the mainstay of the treatment in most of the patient. And moreover, the important is because of the availability of the inhalational corticosteroid, which are going to give a target delivery of the drug and will be devoid of systemic side effects, that led to early introduction of the corticosteroids in most of the patients. So corticosteroid, they are the mainstay of the patient in most of the bronchial asthma patient because of all this. But still we do not use it currently for the mild episodic asthma. In that mild, one is mild, then is episode. Jahan pe episode are there, again main drug we give, that is beta 2 agonistic drug. In rest of the asthma we give mostly the combination of the inhalational corticosteroid along with that long acting beta 2 agonistic drug. That is the mainstay of the treatment. Now what are corticosteroids we have? We have a inhalational corticosteroids. आपके पास कौन inhalational है? We have a oral and we have a systemic corticosteroid. Now, what are the inhalational corticosteroids we have? Inhalational corticosteroids we have, one is baclomethasone, then we have a fluticasone, flunisolide, budesonide, and cyclisonide. Two with this, okay, like this. So what these are the inhalational corticosteroid. ये कौन से हैं? Inhalational corticosteroids. So they have high topical versus systemic ratio. So their activity is more towards the topical, and the maximum is with, like if I take up this is we use even for the nasal allergic rhinitis, also nasal spray, that is also available. This has also got the high topical activity. This one is also very low oral bioavailability. This is also systemically, also systemic activity, it is very less. Systemic side effect, that is very less. But cyclosonide, this has got one peculiar feature. What will happen? Even the local side, topical side effect, they are also less. Whatever seen with the rest, I will discuss that also later on. Whatever seen with the rest of the inhalational, even that side effect is also not seen with this. So what is this? Is a prodrug. Once you give it by inhalational route, it is converted into active drug with the help of esterases, which is present in the bronchial epithelium. So once it is, so it is going to act directly on the site, and once that drug it is absorbed, जो भी है वहाँ पे systemically, that is bound, जो आपकी whatever little bit is absorbed systemically, that is going to bond with the plasma protein. So this drug, it has got the highest the topical systemic activity, cyclisonide. So what are the other? We have a oral steroid. So oral corticosteroids, under this we have prednisone, then we have prednisolone, and then we have a methyl prednisone. So prednisone, it is a prodrug, it is converted into prednisolone in the liver. So when we give This is when we have given the inhalation or whenever the patient with the acute asthma, जहाँ पे आपने patient को treat किया, after the treating the patient with the beta 2 agonistic drug bronchodilator दे दिया with the acute asthma patient. So to suppress further symptoms and to prevent the relapse, ठीक है, to suppress the symptoms and to prevent the relapse, we put the patient on oral steroids. So whenever the patient is taking oral steroid, now again we want to switch over to the inhalational steroid. Switching off this oral steroids, oral से switch over करना हमने किसमें, to the inhalational corticosteroids. This is also inhalational corticosteroids. इस पे अगर आपने switch over करना, then how to do this? So there should be a overlapping of 1 to 2 weeks of these inhalational corticosteroids over the oral, and then with this overlapping of 1 to 2 weeks, with this we have to taper the oral steroid just to prevent what, HPA axis suppression. To prevent this we do this thing. So this is about the oral steroid. Then we have a parenteral steroids. So under the parenteral steroid, so these all the three, they are short acting. Oral steroids are prednisone, prednisolone, methyl prednisolone. We give it for the 7 to 10 days. So if we compare it with the dexamethasone and all, this is a short acting. So then parenteral steroids. So under this we have a hydrocortisone. इसमें आपका आता है hydrocortisone and methyl prednisolone and methyl prednisone. So this is given in emergency. जहाँ पे acute asthma, severe acute asthma, that is the status asthmaticus, there we give a parenteral corticosteroid. Now, what are the important side effects with this corticosteroid? So if we are giving it by inhalational route, it is going to cause the throat irritation. There will be hoarseness of voice. Okay, dysphonia may happen, and then the most important side effect with the inhalational is oral candidiasis. This is very common. And how you can prevent this oral candidiasis? Number one, by using the spacer. Okay, so in between that inhaler, आप inhaler ले लो, inhaler के बीच में there is one more device is there, so that we can use, that is a spacer, so that the particle when you inhale, it is only 1 to 5 micrometer. This particle, it is delivered to bronchioles, and that is going to release the active drug over there. Rest of the particle, they get deposited. The smaller one, they will come out, and the larger particle, they get deposited on the oropharynx, and that is the one which is going to cause the oral candidiasis. So you can use number one, a spacer. So on the spacer, what will happen? The larger particle, instead of getting deposited on the oropharynx, it get deposited on the spacer. This is number one. Number two, gargle. Simple gargle. After taking, every time whenever you are inhaling, you just do the gargling of the throat. That is going to remove whatever the particle is deposited. And the number three, if the person develops this oral candidiasis, then you can use the topical nystatin or clotrimazole. So this is about the corticosteroids. Coming to the next group of drug. So next group of drug is Leukotriene modulator. We have a Leukotriene. So now we know the leukotrienes, they are very important mediator which causes the bronchoconstriction. So these comes from where? From the basophil, from the macrophages. They are going to release what? They are going to release the leukotrienes. So which is going to important is already I have told C4, D4, E4, even B4. They are going to act on the cystenyl leukotrienes receptor and causes the bronchoconstriction. I'll just show this diagram. So now the two way this leukotriene modulator, they are going to act. One is the inhibition of the formation of the leukotrienes. This is number one. Another one is once it is formed, then it is going to act on this receptor. So you can either inhibit the formation by inhibiting this enzyme, or you inhibit the action of this leukotriene by inhibiting this receptor, cysteine leukotriene receptor antagonist. So two group of the drug, they come under leukotriene modulator. One is this lipoxygenase inhibitor. So lipoxygenase inhibitor, important drug we have xylitol, and here cysteine leukotriene receptor antagonist we have zafirlukast, montelukast, iralukast and pranlukast. These are the four drugs, and out of these zafirlukast and montelukast, they are the well established drug. So how this drug, so mechanism of action, that is very much clear with the xylitol. Xylitol kahan pe kaam karti? It is a 5-lipoxygenase inhibitor. It inhibits the formation of the leukotriene in the basophil, in the macrophages. So this leukotrienes, they are not formed. So here the important is this xylitol. It is the most important adverse effect is when this is, it is a hepatotoxic. So because of that, this drug, it is withdrawn. इसका important side effect क्या है? Xylitol, it is a hepatotoxic. So it is withdrawn from the market. It is not used. Now coming to the cysteine receptor antagonist. Cysteine receptor antagonist we have, which is going to inhibit the binding of this leukotrienes to the cysteine receptor. So what are drugs we have? Cysteine receptor antagonist. We have important drug we have zafirlukast. Then we have montelukast. Then we have iralukast and pranlukast. These are the, out of these are the well established. So if you are giving the zafirlukast, it is going to, the food, it is going to inhibit its absorption. So you have to give it after giving the meal, after 2 hours after the meal. इसका meal के साथ montelukast is does not show any interaction with the food. ठीक है? Iralukast, it is just like a montelukast, and pranlukast, this is a newer one. Okay, so this group of the drug, they are mainly used for where? Number one, we use it mainly for the prophylaxis. ठीक है, एक तो इसको इसमें यूज करते हैं. Then we use it for the aspirin induced asthma or exercise induced asthma. ठीक है, now how it is going to help in a aspirin induced asthma? I will again focus the same diagram, this one. Okay, what happens? What aspirin does? Aspirin, it is a cyclooxygenase inhibitor. One very important reasoning question, it is very commonly asked in the exam. Why aspirin? It is contraindicated in patient with the bronchial asthma. Aspirin जो है वो कोई patient है bronchial asthma उसमें हम नहीं देते हैं. Why we don't give? Because aspirin, it is a COX inhibitor. If we give aspirin to the bronchial asthma patient, then what will happen? It is going to inhibit this pathway. Then what will happen? The metabolism of this arachidonic acid will be shifted towards which pathway? This. More leukotrienes will be formed, and which is going to cause a precipitation of the bronchial asthma. So leukotriene receptor antagonists, they are given in the aspirin. अगर patient ने aspirin लिए, if it is causing the bronchial asthma, precipitation of the bronchial asthma, so bronchial asthma, that is mainly because of the this. So cysteine leukotriene receptor antagonist, it is useful in the aspirin induced asthma. Hope it is clear. Now what are the important side effect with this? Important side effect is related to the headache, GI distress, and one important side effect which is reported with this is a Churg stress syndrome. What is this? It is, इसमें patient को होता है, patient will be having vasculitis, eosinophilia, and then there is a worsening of asthma. So few they say this is a side effect with the cysteine receptor antagonist. Few they say because they have withdrawn. Once we put the patient on this, they have withdrawn the corticosteroid. It may be because of the withdrawal of the corticosteroid this then happens. So this is about the leukotriene modulator. I have covered both 5-lipoxygenase inhibitor and cysteine leukotriene receptor antagonist. Now coming to the next one. Next one is a mast cell stabilizer. So you remember again the pathogenesis. So mediator like histamine, prostaglandins, then leukotrienes, all they are released from the mast cell. So they are the drug which is going to inhibit the degranulation of the mast cell. मतलब जो आपका mast cell है, from where the mediator they are stored, they are going to stabilize this. So the degranulation of the mast cell will not happen. So this drug, it is going to act this way. Now how it is going to stop this degranulation, like mechanism of action? Okay. So initially how this degranulation happen, on the surface of the mast cell there are antibody. ठीक है, antibody होते हैं, and then what will happen with the exposure of the antibody, this antigen, it binds with the antibody, and what will happen, this is going to cause the influx of the calcium, and this transmembrane influx of the calcium, once this antigen and antibody binds, this is going to cause the degranulation. So what this mast cell stabilizer they do, they inhibit this influx of the calcium. So there will be no degranulation. So what comes under this mast cell stabilizer? So drugs which comes under this is a sodium cromoglycate. We have a metocromin, and then we have a ketotriphen. So mechanism of action I have told, they are going to inhibit the degranulation. How they are going to do, these are the drugs which come under this. So where we are going to use this drug, it is also present and available in aerosol form. So advantage of this drug is, once we put the patient on this, it is not a bronchodilator. It is not, does not exert any anti-inflammatory action. It is just going to inhibit this degranulation. So we use it as a prophylaxis. Then once you put the patient on this, it is going to decrease the dose of both bronchodilator and also the corticosteroids, or available in the aerosol form, and we give a for the prophylaxis. Once we put, it is going to decrease the dose of both bronchodilator and the corticosteroids. So this is about the mast cell stabilizer. Now the next group of drug is, we have a omalizumab. This is anti-IgE antibodies, this drug. So जहाँ पे भी word आ जाता MAB, this is a monoclonal antibody. So it is a humanized monoclonal antibody. Now how this drug it is going to act? So it is going to inhibit. So usually what happens on the surface of the mast cell, this antibodies, they are IgE antibody. This you can say IgE antibody, they are going to bind. So this drug, it is going to inhibit the binding of this IgE antibody, the circulating IgE antibody which comes and bind with the mast cell, it is going to inhibit that. So number one is, it is going to inhibit the binding. So inhibit the binding of IgE antibody on the mast cell. Second thing is, whatever is bound, जो इसके ऊपर पहले से bound है, it is going to inhibit the activation of that bound form of IgE antibody. It is going to inhibit. यहाँ पे भी ये inhibit कर रहा है और यहाँ पे भी ये inhibit करता है. Third one is, it also causes the down regulation of Fc epsilon receptor 1, which is present. यहाँ पे ये it is bind. This is a Fc epsilon receptor. So it is going to cause a down regulation of this. So antibody will not bound to this. So this drug, it is anti to antibody. So this drug, it is anti to antibody, IgE, and this is also given as a prophylaxis, where the patient is not showing the improvement with the bronchodilator or with the corticosteroids. We give this drug to the patient. The downside of this drug is it is a expensive drug. Okay, so this is all about the drug which we use for the treatment of the bronchial asthma. Now, most of the drug which you can see on this slide, they are available in a inhalational form. So what all drug we have in a inhalational forms? Under the bronchodilator, we have a sympathomimetic, anticholinergic, corticosteroids already I have told, and then this mast cell stabilizer. So these four group of the drug, sympathomimetic हो गया, आपके anticholinergic हो गया, corticosteroids and the mast cell, they are available in the inhaler form. And inhaler form, most of the drug, bronchial asthma patient, they are maintained on this inhaler, various type of different inhaler. So inhaler, what is they are going to give a target delivery of the drug, systemic side effect will be less and easy to use. Now in an inhaler, we have a depending on the type of the drug. So we have a two type of drugs they are in an inhaler, either they are available in a solution form or they are available in a powder form. So जो solution form में है, जो which is present in the solution, तो आपका कैसे है, we have either in the solution form. So solution form में आपके पास क्या है, pressurized meter dose inhaler, and then we have a nebulizer. Solution forming, and where the drug that is available in the powder form, so where we have a spinhaler and rotahaler. We have a rotahaler and we have a spinhaler. I'll just show you one. So this is a pressurized meter dose inhaler. ऐसे दिखता है pressurized meter dose inhaler. So you can see it is easy to carry. ठीक है, पॉकेट में रख लो, कहीं पे भी रख लो. तो here important is you have to press it. This is going to this mainly use propellant. What is propellant used here? Here it is used hydrofluoroalkane. That is a propellant. ये pressurized meter dose inhaler में क्या है? Hydrofluoroalkane, that is used as a propellant. So once you press it, you have to put it in the mouth, and then once you press it, and you have to take a deep inspiration. So coordination, that is a must when you are using this inhaler. So coordination, that is necessary. If another one is where the drug it is present in solution form, that is a nebulizer. Nebulizer mein what is there in a nebulizer? The jet nebulizer, they are also used here. The drug in a mist form that is taken. So multiple drugs they can be given with the nebulizer. Here no coordination is required. You can use it in elderly, you can use in a children. Now in a powder form, we have a rotahaler and a spinhaler. Here what happens, the rota caps, they are there. I'll show you here one rota cap. So this is a rota cap. You can see here the rota cap. Okay. So here the drug, it is in a powder form. So we give it we give this one with the help of rotahaler or a spinhaler. So this is a rotahaler one and this is a spinhaler. So you can see here. So here what we do, so you can put a rota caps into this. So here inside the rota caps they are placed and we puncture it. You can see it is, we puncture it, that capsule, and the drug that is inhaled with this. Okay. So this is the drug, it is present in a powder form. Now, most of this drug which we give by inhalational route, it is already I have told the size 1 to 5 micrometer particles that will be deposited on the bronchioles, from where the active drug they reaches to the bronchiole which are available for the action. So the smaller one they will come out, and the more than this larger size they get deposited onto the oropharynx and leads to side effect, like with the corticosteroid, oral candidiasis, dysphonia, throat irritation with the rotahalers, throat irritation, that is very common. So it can also cause a bronchoconstriction. Okay, so this is about the drugs which we can give for the inhalational form. Now how we are going to treat the patient, asthma patient. Okay, so just guidelines how we are going to treat if the person is with a bronchial asthma. So bronchial asthma, and why we want to treat it, the goal of therapy is to give a symptomatic treatment, like patient with the breathlessness, bronchoconstriction and all that. Number two is to prevent the worsening of the asthma or to prevent the frequent exacerbation. And number three is to prevent the hospitalization of the patient. That's why we treat the patient with the bronchial asthma. If there is a mild episodic asthma, ठीक है, then what we are going to do, mild है और episodes है, then with each and every episode we give short acting beta agonistic drug, and in which form, in a inhaler form, inhaled form. Then if the person is having a seasonal asthma, ठीक है, किसी को seasonal asthma है, then we can put the patient on inhalational corticosteroid 1 week before, sorry, 1 month, it is not 1 month, 1 month before and 1 month after that season. Okay, and in between if there is any episodes in the seasonal, to prevent this seasonal asthma, this is a prevention. So if in between if there is any episode happens, then you put the patient on the same. Then the third one is if the person suffers with the chronic asthma, अगर patient को chronic asthma हो जाता है, then ठीक है, so chronic is further with the chronic if the person suffers with the mild chronic asthma, ठीक है, where there is occasional worsening or occasional exacerbation or less than 1 day or 1 day ऐसे है patient को. So here also we are going to put the patient on inhaled, उसको क्या देंगे, inhalational corticosteroids. और कहीं पे अगर बीच में है अटैक, then we put the patient on beta 2 agonist. Along with that you can put the patient on, if needed, cysteine leukotriene receptor antagonist. Now if it is a moderate where there is a frequent exacerbation, ठीक है, अगर पेशेंट को मॉडरेट chronic asthma है, we are talking about the chronic, moderate chronic asthma with the frequent exacerbation. So frequent exacerbation में इसमें क्या है, we have to give the patient inhaled corticosteroids with the long acting beta agonistic drug. इसका, this is an inhaler form, ठीक है. And the alternative to this is we can put the patient on cysteine leukotriene receptor antagonist. We can give the oral theophylline, ठीक है. Then if it is a severe, ठीक है, अगर patient को severe chronic asthma है, then what to give? So with the severe chronic asthma, again the same thing, inhalational corticosteroids with a long acting beta agonist, ये देना. Along with this we can put the patient on oral beta 2 agonist drug, oral steroid, and then cystine leukotriene receptor antagonist. This is how we treat the patient. And if the patient goes for status asthmaticus, which is a life-threatening condition, it's a severe acute asthma. ठीक है, अगर patient को status asthmaticus, then how to treat the status asthmaticus? It is a severe acute asthma. So it's a life-threatening condition. It needs immediate treatment. So in most of the patient, we need hospitalization. So after the hospitalization, high dose of oxygen, like 40 to 60% of the oxygen has to be given. Along with that, we have to give the inhaled beta 2 agonistic drug, and we can add ipratropium also with this, and then systemic corticosteroids. Systemic corticosteroid, which one? Hydrocortisone. We give 100 milligram IV and repeat after 4 to 6 hours. You can give 100 to 200 and can switch over later on the oral prednisolone. And here, just look for the dehydration. If the person is having a dehydration, give the saline and correct the acidosis. So both this for this we give the saline and sodium bicarbonate. And if the person is having any respiratory tract infection, then put the appropriate antibiotic. Okay, because usually the upper respiratory tract infection, that is the precipitating factor for this status asthmaticus. And if it is needed, then go for intubation and mechanical ventilation. So that's all about the bronchial asthma. Just we'll try to solve few of the MCQ. What are the important, first I'll tell about the what are the important subjective question for this topic. So usually you get the question on the mechanism of action, salbutamol. Discuss the pharmacological basis for the use of following salbutamol in bronchial asthma. So here you are supposed to write the mechanism of action of the salbutamol, like it is going to increase the cyclic AMP both in the bronchial smooth muscle and in the mast cell. In the mast cell, it is bronchial smooth muscle, it is going to cause a bronchodilation, whereas in the mast cell, it is going to inhibit the release of mediator from the mast cell. Then theophylline in a bronchial asthma. So यहाँ पे भी आपने adenosine receptor antagonist, it is a phosphodiesterase receptor antagonist, histone deacetylase, it is going to activate that. Okay, so all that you have to write the theophylline. Then the adverse effect of the theophylline. This is important. Adverse effect of the theophylline, because safety margin that is less with the theophylline. Then another question which is asked, inhalational corticosteroids. Inhalational anti-asthmatic drug can also be asked, inhalational corticosteroids. Then management of status asthmaticus. Okay, we will try to solve few of the MCQ. Which of the following drug is not used in the treatment of bronchial asthma? The first choice is beta 2 agonist. ये हम करते हैं. Sympathomimetic. Corticosteroid, this also we use. Then cholinesterase inhibitor, ये नहीं करते. Phosphodiesterase inhibitor like theophylline. So the correct choice, it is a C. Now next MCQ. the efficacy of salmeterol, it is increased if it is given along with. Now salmeterol it is beta 2 agonist. So what happens, what is the main shortcoming of salmeterol or beta 2 agonistic drug, long acting beta 2 agonistic drug? It causes the down regulation of the beta 2 receptor. So to increase the responsiveness of this, we give this along with corticosteroids. So this is the right choice. Now the mechanism of action of montelukast. So montelukast, zephyr-lukast, era-lukast, pran-lukast, they are the cystenyl leukotriene receptor antagonists. So they are the competitive antagonist of the first choice. Alpha knee, beta knee, they are the there is a competition. So it is the choice is A. Now the next, omalizumab, it is indicated for which one of the following conditions? So easy to recall, it is for the bronchial asthma, not for this, not for this. So it is a monoclonal, humanized monoclonal antibody which is used for the treatment of bronchial asthma. Now which of the following drugs prevent the release of leukotriene and histamine from the mast cell, like which is going to cause stabilization of the mast cell membrane, or which is going to inhibit the degranulation. So we know it is a mast cell stabilizing agent. We have the three, sodium cromoglycate, then we have a nidochromil, and then third drug we have a ketotifen. So here the right choice is nidochromil. The most common side effect of inhalational baclomethasone is correct choice, oropharyngeal candidiasis. And how you can prevent it? By using the spacer device, by gargling, okay? And then if it happens, then we can use nystatin and clotrimazole, that is an antifungal drug. Topical we have to use Gilutine. Gilutine, this comes under leukotriene modulator. So leukotriene formation, either you inhibit the leukotriene formation, or once it is formed, you give a drug which inhibit the action of those leukotriene on its receptor. So Gilutine, it inhibits its formation by inhibiting the enzyme 5-lipoxygenase. So it is a 5-lipoxygenase inhibitor. So that's all about the bronchial asthma. So if you like my video, please give a big thumbs up, and if you have any query, you can ask in the comment section.